Hello. It's very difficult to talk after such a brilliant amount of information, but I'll do my best and I'll give you some ideas and insight into breast ultrasound. Keep talking. Okay. My name is Dina, and I have come just as the course organizer mentioned. I've come all the way from Scotland. So I'm no god, just a mere mortal. But, and my talk today will be, one of the talks over the course will be about the breast ultrasound. So I've been working as a breast radiologist for 17 years, and I am doing all kind of breast imaging, just name it. So ultrasound is considered to be bread and butter of breast radiology. So this is a part of a hospital where I'm working, and in Aberdeen in Scotland, the trust is large. Location-wise, I think it's second largest in Europe. It consists of multiple hospitals, and this is just a part of it. And it's very, very nice, or bony, as Scots say, so I thought I'll put this in my presentation. I do love Scotland. It's a beautiful scenery, so I will fill my presentation with the pictures. It will help you to stay awake, hopefully. And I'll be very, very quick. I know you're all bursting for a coffee, and so that's why I'll try to be very efficient and see if you can implement some of the great talk of Jeff that just did to my talk as well. So when do we use breast ultrasound? So obviously to image the breast as a part of symptomatic services. So the main aim is if we do the mammogram, which most of the time is a primary imaging modality, we see if the finding we can see on mammogram is benign or malignant, and then whether we are looking at a cyst or a solid mass. We can't see the lesions, which normally we see only on one mammographic projection, for many reasons. It could be too soft, it could be not included in projection, it could be obscured by breast tissue. And then if there's a finding clinically, which we can't see on a mammogram otherwise, and also if it's not included in mammogram, if we have a nipple discharge, mammogram quite often is negative, but on ultrasound we can see reasons why it happens, and if there's a breast swelling. As a part of neoadjuvant chemotherapy follow-up, ultrasound is one of the modalities, again, going hand in hand with mammogram. In the screening settings, second look ultrasound after mammogram and MRI, and also guidance of interventional breast procedures. So I will look at each of these topics separately and will provide you with the pictures as well. So first thing, ultrasound features, the things we are appreciating when we're looking at the breast and ultrasound. I must say the ultrasound machines nowadays are absolutely amazing. And I tell to my registrars, I say, you actually only need to know the normal anatomy and machine will just show you everything. So when we are appreciating ultrasound features of a finding, we're looking at the echo pattern, orientation of the lesion, the shape of the lesion, we're checking the margins, we're looking at echo transmission, and then also we appreciate blood flow and elasticity. So there'll be a next talk after coffee break by Professor Bamber on these two, but I will just show you a couple pictures. You surely have seen it all and know it all as well. Now, when we're talking about the echo pattern, we're talking about the lack of pattern or anechoic. So most of the time we just see a black hole. And we do know that fluid most of the time is black. We can have an increased echogenicity area. I would know how it works. I'll just use the mouse. So increased echogenicity area. My mouse doesn't work. Okay. And then we're talking about the area which is the same echogenicity as the surrounding fat tissue. Now, talking about echo pattern, we always compare the tissue with that's right. Thank you very much. Thank you. So we always compare to the echogenicity of a fat tissue. So everything that is darker is hypoechoic, everything that is same is iso, and everything that is higher in echogenicity will be hyperechoic. We also may have mixed echogenicity areas, whereas there is a cystic areas and a solid components. It could be cancers, it could be complex cysts, and then we're speaking about the heterogeneous echo pattern. Hypoechoic, as I said, is just darker, but it's not cyst, so we know it's not fluid, it's still solid lesion, and in this case, very well defined, nice, typical fibroadenoma. Orientation would be the next thing. So horizontal orientation is most of the time is for benign lesions, and that means that a horizontal axis is longer than a vertical. Yeah, so it's wider than tall. And they can be taller than wide, and then we're talking about a vertical orientation. So the top to bottom measuring deep, this measurement is way larger than a horizontal one. And this is quite typical for malignant lesions. Although scars sometimes may be vertical, but then there are other features you appreciate. Now we're moving to the shape. And shape is oval. Again, we do know that this is most likely for benign lesions. Round ones, a tricky one. So the lymph nodes can be round, the lesions, the malignant lesions can be round. Mucinous carcinoma can be very, very round. Metastasis can be round, but also the fibrinomas sometimes can be round. And then irregular shape, when it's not round, it has no nice margins, and we just know that this is not a shape we can actually put in a particular box and say this is oval or round. Margins, again, circumscribed. This is just the combination of all the benign features, and it's very well defined, so you can literally take a pencil and draw all around the lesion and have them nice and sharp. You can have them irregular, and irregular margins can be whether microlobular, so you can see just a very mild waving of the margins, and they can be spicular, and then you know there's a fibrous component in it, and it can be angulated. This is quite typical for malignancy, and it can be very, very subtle and distinct, and you don't really, you can't really appreciate the margins. You can say it's irregular, but you can't put this into any other category. So echo transmission or shadowing or lack of it would be something we would be looking up here. So any absence of the shadowing, in this case, this was a malignancy, and there was nothing behind it. That was just a normal fibrous tissue, not a part of a tumor. You can have a dorsal acoustic enhancement, quite subtle here, but you see the tissue behind the lesion is slightly brighter, which indicates the presence of increased water in a lesion. You can see the bilateral shadowing, and this is one of the very pathognomic features for benignity. So these lateral shadows come from both sides. If you have only one shadow, only from one side, well, that might sharpen your attention, because that might mean that you don't have a typically benign lesion. And you can have acoustic shadowing, where you don't really see the tissue behind the lesion because there's this wide shadow behind. Now, blood flow characteristics, we're looking at distribution. We can see how many vessels are there, and the newest and very sensitive machines is providing us this information. And then there are some other criteria which you can measure. It's less used in breast. Most of the time we don't, especially in a very intense work environment. But these are all the things we can appreciate also in a breast imaging. So here you can see a very beautiful central blood flow in abnormal lymph node, metastatic lymph node, that was proven to be malignant. And you can see, well, in this case, quite subtle but central blood flow within a cancer, nothing in periphery. This was also central blood flow within proven papilloma. It sits next to the knuckle, and there was association with the milk duct. It was actually benign lesion. And then Peripheral blood flow, not very prominent here, I would say. Now, about the ultrasound features, we can measure elasticity. Just as I said, that Professor Bamber will tell you more about the physical features of this, but there are several ways we are using, and elastography, as per se, is a great tool to reduce the number of biopsies. In Scotland, there are several centres which are actually using elastography as a part of assessment of breast screening patients. And if the elasticity of the lesion proves to be benign and within benign rate, then they do not perform biopsy. So I would say in the screening in UK and in Scotland where I work, the approach is quite aggressive. So we very rarely score lesions as 3 on ultrasound. We'd rather go ahead with a biopsy and prove that this is benign or malignant. So elastography helps a great deal to reduce the number of these biopsies, which quite often come back as a benign, but we don't dismiss solid lesions on screening, mostly because they're small and they can be occult small tumors. So strain elastography, it measures how stiff or how hard the tissue actually are, and a shear wave provides us information how quickly sound travels through the tissue. And depending on the findings, we can say that this is benign or malignant. Now, the programs are very clever, and they show you also the grading on the side, so they can tell you whether the measurements are regarded as soft or hard tissue. So, and as I said, elastography hugely improved the diagnostics, and you can differentiate between the lesions and reduce the number of biopsies. So this is within fibroadenoma. So this is what I said before. So this is soft. So everything that's blue, it's soft, and everything that's red, it's hard. So you see it's quite mixed, and the hard areas are more related to the areas of fibrosis rather than not, but tumor would not ever look like that. So that is a benign fibroadenoma. It was not biopsied at the time, and lady came 3 years later with no change, and that looked even better than this one. And this is a cancer where you can see, so cancer is here. This is a malignancy, and it's completely red. You can see the fat tissue next to it. You can see some normal breast tissue, and this is a malignancy, and it's completely hard, as you can see. Now, going slightly cutting all this down now to the lesions, how do we know, and what are we expect to see when we see the lesions in ultrasound? So talking about the cyst, which is the most often finding in a breast, symptomatic, asymptomatic, I would say 99% of female in a certain time of their months and age do have cysts. So this cyst is not disease. It's just a, I would say, hormonal representation of their hormonal background. So cysts can be simple, and they are well defined. You can see bilateral shadowing. You can see the dorsal enhancement. It contains fluid, and most of the time, if you would put a needle in and drain it, it would collapse completely. So these are all very typical signs of the cyst. The cysts can be complex as well, and they can be complicated. And this is where we extend our investigation. So if we can see, and I will move and I'll show you the differentials for hypoechoic lesions as well. So, So the complex cyst is still cyst, but it contains dense content, and this can be insipated cyst or the cyst after drainage if it bleeds, and then you can have a picture like this. And other way around. So, and if you can see within a cyst actually masses and a blood flow, then you speak about, it's other way around, you speak about complex cyst. So in that case, you can see a different outcomes. You can have a papilloma, you can have a cancer, but you also can have just a normal cyst with a dense content. This is a very famous Scotland cow. Everybody goes and takes a picture. I thought I'll make your day as well with it. If I would go back, so differential diagnosis, if we see a hypoechoic lesion, always would be the same in a breast. It's whether ductal cancer or lobular cancer. metastasis. I don't know how much you've seen them, but it's a fair amount of metastasis seen in breast as well, and lymphoma, of course. So just to sum up now the criteria for benign lesions. So we do know the lesions are smooth, they're well circumscribed. You can take your pencil and draw a line around it. So they can be hyperechoic, isoechoic, or mildly hypoechoic. Though this is not carved in a stone, you have to appreciate each and every situation as you go with a case. You can see a thin capsule around it, which most often is whether suppressed back tissue, normal breast tissue, or with benign lesions, it is an actual capsule. Shape-wise, they would be ellipsoid, and they would have a horizontal orientation. The lobulations are very few. They say 3 or fewer, I would say up to 5, but no one really counts them. When you see the lesion, you do have a feeling that this is a benign. And then if you don't see any other absent features, which would be lack of lateral contour, dorsal shadowing, or the margin irregularities, then you're speaking about a benign lesion. So these are criteria on ultrasound. Looking at them, if you have any of those, you can align positive predictive value. So having that feature increases the possibility of cancer, and you see the speculations is the highest criteria. Also, if you have a vertically orientated lesion, again, the value is above 81, so that is quite a lot. And also, look at the margins, shadowing. If you have hypoechoic lesion, again, it's quite high up. Also, presence of calcifications, though, mind you, calcifications with the newest machines, you can't see them, but please, please, please don't analyze calcium on ultrasound. It's not possible. The particles are too small. You can see them, you can mention them, but don't put a description of calciums. This is a grave mistake, and this should not ever be done, especially alone, because the white dotted hyperechogenicity, as for calcium, can be also from fibrosis, it can be from a normal breast tissue, it can be from many, many things. You see them, you can point them out, you can tell about them. You do see big, well, I say bricks of calcium, which is calcified fibroadenoma, but you do not analyze them. You don't describe them. That's why you have a mammogram. Yeah, and the lobulations and the branching pattern, when you can see the ducts branching with the masses in, this again could be a very, very strong criteria for malignancy. We're getting there, coffee's coming soon. Right, so this is just a list of benign breast lesions. And the reason I'm talking about the benign breast lesions is, just as I said at the beginning, if you know normal anatomy, everything that comes across, you know this is not normal. And when you know what not normal is benign, this you can just dismiss, and you can turn to something which is more important, which is malignant, which requires further investigation, more work. So the benign lesions, we know cysts, where they touched them and had a look at them. Abscess, galactocele, you always have an information, especially in the symptomatic services. The lady comes, and that's why there goes this assessment with many, many areas. Seroma, hematoma, you know where they come from. There should be, episode of a trauma or a surgery or any other intervention. Liponecrosis, evidence of trauma in the past. Hemangioma, fibroadenoma, so these are the lesions where we describe them, and these are all benign lesions. Phylloidous tumor is a special entity, and surgical colleagues will know that as no one else. Fibrous proliferations, which may cause mass-like lesions. You all know that this is something that makes us radiologists sweat a bit, and we don't know what to do with them at the times. Again, they are all benign: hamartoma, papilloma, inflammatory changes, and a lymph node, which quite often is area of extra assessment after mammogram. I will only very, very briefly touch BIRADS, because there will be talk on BIRADS tomorrow. So you do know the categories. We have 7 of them. They do slightly different in Europe and in UK, and I have had a chance to work with all those approaches, and I have had done the three BIRADS 3 oldish follow-ups, but as I said, in UK we would have a more aggressive approach, and in a way it provides us with more work in terms of biopsies, but it also helps us to dismiss benign lesions or probably benign lesions without doing biopsies using all the other tools we have. So we would rather do the biopsies rather than follow-ups, and that gives a diagnosis to the lady quicker, so we cut these extra appointments at that time. But this is the BIRADS, which is a world accepted, and this is how everybody works. Yeah? Suspicious is cut into other subcategories. And BIRADS 6 is a known biopsy, is a known cancer, and this is most likely when the ladies are undergoing additional imaging or neoadjuvant chemotherapy ladies. Now, we can have lesions which are benign but look very, very malignant, and this is abscess, hematoma, radial scar, I love radial scars, post-surgical scars, diabetic mastopathy. You have to have type 1 diabetes, and quite often these are young girls with weird lumps that come out of nowhere. They look absolutely malignant and horrifying, and it doesn't matter how many times you do the biopsy, they always come back as non-specific benign changes, unless the pathology helps us out. But then we have to give them that idea that this could be diabetic mastopathy. Sclerosing adenosis, and then different benign tumors, which look very, very benign, very, very malignant, sorry. And also lymph nodes due to other changes. Again, they're reactive, they look malignant, but they're not. Now, a special entity would be hyperechoic lesions. I did say before that hyperechoic lesions most of the time are benign. Well, not always. So we do know that there are lesions, there are findings in ultrasound which do contain fat and are white on imaging, but they are not benign. So you can see that everything that contains fat can be white, and these can be fat necrosis, lipoma, hamartoma, angiolipoma, but you also can have liposarcoma. Again, there are other criteria, there are other features to the lesion. We're talking about the echogenicity just now. Now, fibrosis also is white, and you can have hamartoma again, and you can have a focal fibrosis, which gives you a very nice and prominent bright patch, and you don't know what to do it because it's ill-defined and irregular. And you can have a PASH, which is a benign condition of the breast, but you also can have invasive tumors, ductal or lobular, and lobular cancers are naughty. They can be hyperechoic or mixed echogenicity quite often, and we quite often may dismiss them because they're not black, so they don't come across straightforward as a malignant one. And also the lesions which are of high cellularity, containing a lot of cells, also may be hyperechoic. Benign is infection. It would be more mixed echogenicity, but you can have, again, you can have a ductal cancer, you can have DCAS, which is a night and white spot of something, and lobular cancers, lymphoma, or metastasis. Now, in the screening settings, we are doing ultrasound for assessment, and this is the other modality after mammogram. So if you call lady back, she would have additional mammograms and an ultrasound. And it's breast screening per se is a great tool, and we all are using it. So the criteria for using ultrasound or for using modality for breast screening should be high sensitivity, high specificity, cost-effective, safe, and acceptable. So mammography sensitivity is very, very high. It's lower in a dense breast, but Dr. Wurtzes will speak about that more, about the dense breast and the challenges the mammogram provides us in the dense breasts. So there are particular countries which are quite reluctant to use mammogram, and I would say for the screening, but this is just my opinion, which I'm sharing with you, I would say there is no better way how to screen the ladies initially, because you have a general idea of the breast. Ultrasound, in these terms, most of the time would give you less information. Automated breast ultrasound gives you a lot of information, but that again has some pros and cons. However, it's proven that a mammogram and ultrasound significantly increases sensitivity in a breast tissue, especially dense breasts. And you can see how significantly those numbers increase. And that the more cancers we detect, the better we work. So ultrasound usage in a screening is time-consuming and highly operator-dependent. And we would have a little bit more of recalls from that. But then again, I'm only touching this very lightly. Neoadjuvant chemotherapy follow-up. So the ladies which are having their initial imaging, they would have interim follow-ups with mammogram and ultrasound, and this is a great way how to appreciate how the tumor responds to chemotherapy. And I would say it always should be used together, hand in hand with mammography. So this is the same lady, neoadjuvant follow-up treatment. It's a different machines, hence the images differ, but it is the same lady. So the tumor in the left breast upper aspect, you see it initially, it's about 2.5 centimeters. And after neoadjuvant chemotherapy, and this is after 3 rounds only, you can see only a little bit of clip in it. So it's a complete response after 3 cycles already. Second look ultrasound is a great way how to pick up more findings which can be seen only on one modality, and a second look is because we do this after this other modality is performed. So having MRI in preoperative assessment, because of the lobular cancers, because of multicentric, multifocal cancers, because we have inconcordance between the tumor size on these 2 basic modalities, or mammographically occult cancer, we quite often pick up the lesions on MRI on this, which were not picked up on initial imaging. So this is where the second look ultrasound is absolutely great. And it actually does increase the cancer detection rate up to 30%. So these we pick up to 1/3 more cancers in the breast if we're speaking about these 4 main groups in MRI and preoperative assessment. We also pick up more benign features, which leads us to do more ultrasounds, but we can also found quite a lot of lesions we don't need to do anything else. And these are specific criteria in MRI, and seeing them and having them, we know we don't have to do the second look ultrasound. So just like one of the last slides, so I would say one of the main thing is, and it's not only the new doctors would be guilty of, but also very experienced doctors sometimes. So we all have search of satisfaction. We see the tumor, we see something small behind, and then we kind of zoom out and we miss the small bits. We're so excited about finding that one bit that for some reasons we miss other bits. So this is something very to work on, and it's great when you can really zoom out and not to do that anymore. I would say the main denominator, the most suspicious feature would be the one you base your outcome and a diagnosis on. So you see the margins, you see the shadowing, and then putting this all together, that will make your diagnosis. And always follow BIRADS, because the BIRADS is a great way how to give a united and a very common idea what exactly radiologist is looking at. And that's like a common language between everyone. And as I said, most malignant feature would be your main denominator to base your scoring on. Thank you.